So we're going to move on to a case that's quite, relating to a common cancer and a common presentation. So this case is of a 60-year-old man who's otherwise fit and well and has no known family history of prostate cancer, but reports some increasing lower urinary tract symptoms over the last 2 years. Very subacute presentation. And his first PSA performed by his general practitioner returns back at 12. And the doctor performs a digital rectal examination and feels a normal feeling prostate. So that's stage T1C, so non-palpable disease. And so based on the PSA, the symptoms and his age, he's referred to a urologist for consideration of a trust biopsy, which he undergoes, and that shows Gleason 3+4 = 7 adenocarcinoma. So the Gleason score is an important histological grading system used in this cancer, and 3+4 is a significant number, and that's found in 7 of 12 biopsies with up to 80% core involvement. In a case like this, where he's got Gleason 7 disease, that actually predicts for significant risk of clinical progression and cancer-related clinical endpoints. So he actually, we stratify localized prostate cancer into low, intermediate, and high-risk disease, and based on his tumor characteristics, he fits into the intermediate risk group with a Gleason of 7. That intermediate risk, for those that are interested, is also in some classifications split into two, into a favorable and an unfavorable group. Now, what's really amazing about this cancer, in my opinion, is that there are many treatment options for patients diagnosed with localized disease. So these are patients that have cancer confined to the prostate and or the seminal vesicles, and without evidence on staging CT, bone scan, or in these days a PSMA PET, of any nodal or distant metastases, including visceral skeletal metastases. And so for this man, he's got essentially 3 options for treatment. Active surveillance is not appropriate in patients that are non-low risk. And so, 3 modalities, including radical prostatectomy, of which there are a variety of approaches these days. Brachytherapy, which is a form of radiation therapy, which is not always delivered in all centers or available, but that's using sealed sources to deliver a very local treatment that does require an invasive procedure. And also radiotherapy by way of external beam radiotherapy. Now, in some men with intermediate risk prostate cancer, particularly the unfavorable intermediate risk group, they also benefit with a short course of what we call neoadjuvant androgen deprivation therapy. So this is using hormones to cytoreduce tumors, and this has been shown in randomized studies to improve clinical endpoints, including overall survival. What's really amazing about localized prostate cancer is that any modality, any active treatment modality actually results in very similar outcomes. And this has been borne out in multiple studies and meta-analyses, so that's where they pull large groups of data sets from randomized controlled trials. And it consistently shows that external beam radiotherapy actually is equally efficacious as undergoing radical prostatectomy. Now, external beam radiotherapy, which is what you guys are going to see, firsthand today after this presentation, involves using megavoltage photons or X-rays to aim these beams from a variety of angles to a very localized target. And these days, as Sandra Turner talked to at the start of this presentation, is really sophisticated these days. And essentially, beams are directed, and within each beam we also have the power by way of something called intensity modulation to actually change that one beam into infinitely number of smaller beamlets to actually modulate the beam throughout to conform to the target. So it's really fascinating. Now, what this IMRT allows us to do is conform the dose. So the dose in green here correlates to like the prescription dose. So that's really the dose that we're after. I just want you to cast your eyes on what IMRT can do. This is the rectum outlined in brown, and this is the anterior rectal wall. And what you can see is that this technology now allows us to essentially spare the anterior rectal wall like never before. Now, if you talk to somebody who had external beam radiotherapy 15, 20, 30 years ago, often, those treatments, which are now outdated, did result in a lot of this rectum, and particularly the anterior rectal wall, to receive the very high doses. And this is what, led men to have higher rates of rectal complications. And during the planning phase, we also sometimes request MRIs to help us delineate the prostate, which is very important and routinely done at this institution. At the end of a treatment course, a GP and any involved healthcare provider will receive a treatment summary. This is not always easy to understand to somebody that isn't or has no experience with radiation oncology, but essentially it should have a diagnosis, what treatment was delivered, and something about the radiotherapy in terms of the dose that was delivered, the number of fractions or individual treatments, and the technique that was used. So in localized prostate cancer, VMAT or IMRT. And also, most importantly, what is the clinician going to do in terms of follow-up? Now, I'll just touch on a few side effects. But side effects really do depend, on site that's being treated, the dose that's being delivered, the size of the volume being treated, the location of the tumour, and also an individual sensitivity to radiation. And we break up side effects or toxicity into early versus late. Early happening during treatment or before 3 months or 12 weeks. And late effects typically are defined as those that occur after 3 months have passed since completion of therapy. Now, interestingly, alopecia, which is a side effect of some chemotherapy agents, only occurs in patients receiving treatment that involves irradiation of the scalp. The take-home messages are here. That radiotherapy, particularly modern radiotherapy, is a well-established, safe, effective and cost-effective treatment for the management of cancer. It's generally very well tolerated. It's easy for patients. It's relatively low cost compared to a lot of other cancer treatments. Access is improving in Australia, which is a great thing, particularly in regional and remote areas. And that GPs play a vital role in improving radiotherapy use.